Hello and welcome back to another edition of Wellness Wednesday, where we share practical tools, wellness tools and techniques from experts on topics that are important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger, and I'm so excited to be back today. And welcome back our guest today, Dena Goldberg from DenaDNA, where we're going to be talking about genetic counseling versus genetic testing and the difference between those. Dena has a lot of great information to share today. Before we get to that, though, I do want to say a heartfelt thank you to everyone who participated in our Dashing Together program earlier this month. I'm excited to say that so far we have raised almost $190,000, which is incredible, but we're not done. So the donations are going to be open until the end of August. So if you haven't made your donation yet, please go ahead and do so. Or if you've made a donation and you want to make an increase to that, we would definitely appreciate it. Remember that all of these donations are going to help those affected by pancreatic cancer and their families, and help for early detection research as well. As I said, we are here today with Dena Goldberg from DenaDNA, and she is a licensed and board certified genetic counselor. DenaDNA and Dena are based out of Los Angeles, California. I'll let Dena do the bulk of sharing on her background and what she does. I do want to, though, say that throughout the session, please look in the chat and put your questions in there. We'll be saving all of those till the end to make sure everybody gets answered. But please be sure to put them in there. And I'm sure you're going to have a lot of questions for Dena today, because we did in our prep session. Welcome, Dena.
Hi.
Hi, how are you?
I'm good. How are you? I'm excited. All right, let me start sharing my screen. Awesome. All right, well, hi everyone. Thank you so much for having me back. Today, we're going to talk about the difference between both genetic counseling and genetic testing, and direct-to-consumer at-home DNA kits in comparison to medical testing that you would get through a healthcare provider. So first of all, hi, I'm Dena. I'm a genetic counselor and now content creator. So I create content to educate people about genetic counseling and medical genetics. I used to work at UCSF as an endowed counselor of hereditary GI cancer prevention, and had a real special interest in pancreatic cancer. It was part of the Pancreatic Cancer Consortium, and have done research on pancreatic cancer that we're going to be publishing very soon. So I'm excited about that. I also founded DenaDNA, and I'm currently seeing patients through a telemedicine company called Genome Medical, which I will get into later today. I'm also on many forms of social media, so I would love for you to follow me and send me any questions or messages there as well. So let's start out with the big question that many people are probably thinking if you haven't seen me talk before. What is a genetic counselor? Well, if you think about the fact that most doctors and other healthcare providers only really have a very basic genetics training in medical school, if any, and genetics is constantly changing, then you'll understand why there needs to be a sort of expert in the area that can keep up to date with all the new changes in genetics. And since genetics is the future of personalized medicine, really any healthcare team working with genetics should have somebody who understands the ever-changing field of clinical genetics. So that's where a genetic counselor comes in. We stay up to date on the latest research and recommendations in genetic testing, as well as translate complex information to patients, communicate with a healthcare team, and we are trained to deliver all this information in a way that's ethical for the patients and their families, and really culturally tailored to each situation. So if you haven't yet, I highly encourage you to see my previous talk. I talked a lot about the genetics of pancreatic cancer and explained a lot of the basics of just genetics and cancer in general. And I think it's a really, really great primer. I'm going to go over a few of these concepts today real quickly, but if you are interested in learning more, which I hope all of you are, please see that from last August on the Rolf Facebook page. So just to review, last time I talked about the difference between exocrine and endocrine pancreatic cancer. Exocrine being the most common type, where you have the ductal adenocarcinomas, or what we call PDAC or PDAC. That's what most pancreatic cancer, when we hear that term, is referring to. But some are referring to some of these other tumors, including endocrine types, which are called PNETs, or pancreatic neuroendocrine tumors. So that's something important when you're thinking about disease prognosis, diagnosis, and genetics. We also talked last time about the different risk factors for pancreatic cancer, including smoking, chronic inflammation of the pancreas, also called pancreatitis, alcohol use, obesity, diabetes, and genetics. And we talked about the different syndromes that are associated with pancreatic cancer syndrome. So we have hereditary breast and ovarian cancer, Lynch syndrome, FAMMM, Peutz-Jeghers, PALB2, and several others. These are all syndromes that should be tested for on a panel when someone has genetic testing for pancreatic cancer in themselves or a family member. And we talked about why to have genetic testing, and that includes prevention and treatment. So prevention can help with screening earlier or more frequent, and this is for patients and their relatives. And also medications for prevention, lifestyle changes, and in some cases surgery. And then treatment, there are targeted treatments that can aid somebody who has one of these mutations in a better way than a traditional chemotherapy. So that can include something like a PARP inhibitor or immunotherapies, depending on someone's genetic test result. So it's not just for prevention, it's also for treatment. So we talked all about that last time. Again, I encourage you to watch that video. But today we're going to really focus on the difference between what genetic counseling and what genetic testing is, and the difference between medical genetic testing and direct-to-consumer testing. So let's start out by talking about genetic counseling and genetic testing. So these are two parts of the session that's done when someone goes in for genetic counseling, and they are very separate. You can have one without having the other. So what is the difference? Well, genetic counseling typically involves taking a full personal history, a family history, discussing risk factors outside of that, explaining the different testing options, and having a real discussion we consider shared decision making. So helping guide our patients through whether or not they want to undergo testing, depending on their risk. And for some people, they actually come in and they think their risk is much higher than it truly is, and they may opt not to do testing because it's probably unlikely to show anything. So it can happen that way. Some people, it's not the right time in their life to do testing, and that's okay. So that's all part of this discussion process that happens before someone does testing. It also involves an explanation of the limitations to testing, because no genetic testing is 100%. And it addresses anxiety and other concerns such as discrimination or financial strain. And then once somebody already has results, the genetic counseling post-test can also involve explanation of the genetic testing results, care coordination, and determining who else in the family needs testing. So all of that falls into this category of genetic counseling. The genetic testing part of this is simply just the test. It is collecting blood, saliva, or a cheek swab to send to the laboratory, and then the laboratory will analyze that DNA and send the report back to the provider. So those are, again, two different things, and this is traditionally how it works. So our traditional model is that a patient gets referred to a genetic counselor, goes through pre-test genetic counseling where all this information is collected. If they choose to undergo genetic testing, then the sample is sent to the lab. The laboratory analyzes the sample, and that usually takes a few weeks. And then the results are sent back to the genetic counselor or ordering provider, and a session is had to explain what the results mean in terms of that particular person, their family, and their personal history. So it takes all of these factors into consideration, not just genetic testing. Now, because so many more people these days are doing genetic testing, because the price has gone down, the technology has gotten better, there aren't as many genetic counselors to be able to have both the pre and a post-test session anymore. So many people are doing what we call post-test genetic counseling only, where a doctor or other healthcare provider may order a test, or somebody is tested through a screening, maybe event or a community screening, and the laboratory looks at their sample, and then they get the results from a genetic counselor who can then go over the results and their other risk factors and put those two things together. But some people don't realize maybe that this is a service that's readily available, and they know, maybe they see advertisements online for these tests that you can order online. And so they do this thing called direct to consumer testing, meaning that the consumer or the patient would purchase a test online, and there's usually no discussion before this test. There's minimal education, if any, and they usually order it because it's on sale, not because it's the best test for them. And then they get the results from this commercial laboratory, and it's not typically comprehensive testing. There's almost no post-test education, or if there is, a lot of times it's not as available or not as easy to access. So that's what we call this direct to consumer route. So if you think about genetic counseling in combination with genetic testing, when we evaluate someone's risk for something such as cancer, such as pancreatic cancer, we want to look at the whole picture, not just genetic testing. And that's where genetic counseling can take into account someone's personal history, their family history, their risk factors, and their genetic test results. Whereas some of this other pathway, like doing something without genetic counseling, is only going to give you genetic test results. And so somebody who has all these risk factors and a strong personal and family history of other risk and has the same genetic results as someone who has no risk factors are going to be told they're at the same risk if all they do is genetic test results. So that's where genetic counseling can really help give somebody a comprehensive evaluation. So I like to think of it in a way that the genetic counseling portion of every session I do is really talking about all these things outside of the test. And then the test with the counseling gives us really the best whole picture. So now let's talk about what is this direct-to-consumer testing that I was talking about earlier. Well, direct-to-consumer testing, or DTC, are defined as any tests that are marketed directly to a consumer without the involvement of a healthcare provider. And these tests are also called direct access genetic testing at home, or home DNA tests. These have typically varying levels of evidence to support their claims. And ancestry testing or genealogy testing can be linked to these. So many of these ancestry sites have added health on top of their already genealogical data. And so that's what we're going to be talking about today. We're focusing on the health part of direct-to-consumer testing. So in the US, genetic tests fall under the regulation of the Food and Drug Administration, or FDA. And in general, direct-to-consumer genetic tests for non-medical, general wellness, or low-risk medical purposes are not reviewed by the FDA. So that means testing for traits, testing for things like exercise, diet, things that the FDA considers to be lower risk, maybe what supplements you should take, things like that. Those are considered low risk and are not regulated or don't require pre-market review. Whereas moderate to high risk medical purposes are generally reviewed by the FDA. Now, what does the FDA actually look at? They look at whether a test can accurately and reliably measure what it claims to measure. So can it actually find these genetic changes? They look at whether the measurement is actually predictive of a certain state of health, meaning does this genetic change they find actually cause a health issue? And then the last thing they look at is what the company says about their test and how well it works. So are they false advertising? Are they marketing it and leading the consumer down the wrong path? So that's what the FDA looks at when they're looking at these tests. And something straight from the FDA website that I think is important to just acknowledge is that once a company, a genetic testing company, has their test reviewed by the FDA, then the floodgates almost open and they are able to get other tests launched without this pre-market review. So in other words, what does this mean? It means that much of the direct-to-consumer genetic testing market is unregulated. So this is just one of the points that I want you to take home, is that there's really very little regulation right now when it comes to genetic testing. And that's not just direct-to-consumer, that's just any genetic testing, actually. So genetic testing ordered by a healthcare provider is much more comprehensive than the majority of these at-home direct-to-consumer genetic tests. But why? Now, I made a video about this that I'm going to share with you because I think the animations make it easy to understand. But before I show you that, I think it's important to know that most direct-to-consumer genetic tests use the technology we call single nucleotide polymorphism, or SNP testing, or genotyping. And that's looking at bookmarks along a gene. Whereas the health testing that you would do through a healthcare provider would include next generation sequencing as well as duplication deletion analysis, meaning it's looking for spelling mistakes along the whole gene or pieces missing or added. So it's much more comprehensive. So here's a little animation that I think really explains it.
Now imagine every gene as a string of thousands of letters, specifically A, C, G, and T, the alphabet of DNA. Everyone's genes are spelled a little differently, and for the most part, we know what letters to expect at what points and which spelling changes hurt the end product of the gene. Two of the most common technologies used in genetic testing today are next generation sequencing, or NGS, and SNP or SNP testing, also called genotyping. SNP stands for single nucleotide polymorphism, which just means one letter change. These are just two different ways of looking at the same genetic code. Sequencing involves reading through each letter of a gene to look for any spelling changes. SNP genotyping only collects information at specific hotspots along a gene. But for ancestry testing, we use these hotspots since we know the locations of the letter changes in different genetic ancestry groups. These markers act as bookmarks along the genome and don't tell us much about the function of the genes themselves. But for ancestry testing, we really just care about if these markers are there. But for health, the function of the gene is more important. We want to know if the gene is making the correct end product. So it's important to look at the whole gene for any changes that could possibly affect its function. Here's an example of a few different people who each have a genetic change in the same gene that causes a disease. Let's see how the different tests do in detecting them. If we use SNP testing, we'll find some, but not all. And that is not a complete test if you're trying to look at your risk overall. If you use sequencing, it will detect a lot more. You can see the missing pieces here.
Okay, so hopefully that gave you a good idea of the difference between the different technologies that are used in medical testing versus some of these at-home tests. Now, I want to give a real-life example that's going to be relevant to this group. When we talk about hereditary pancreatic cancer, one of the most common genes that we think of is BRCA or BRCA1 and 2. And 23andMe offers testing for 3 specific variants along a gene, but not sequencing and not deletion duplication analysis. So what does that really mean? And that's what I want to show you. So this is taken directly from the 23andMe website, where they're talking about their first and only FDA authorized direct consumer BRCA test. And they very clearly show that there are 3 variants that are looked at. These are what we call the Ashkenazi Jewish founder mutations. So these are the 3 that are most common in Ashkenazi Jews. So if you have a BRCA mutation and you're not Ashkenazi Jewish, it won't be one of these. Very unlikely to be, at least. And it also says straight on the site, this test is not meant to be used to make medical decisions. So it says all over, don't use this test for medical decisions. I just don't think that a lot of people see that. So I wanted to kind of show you a visual example of what happens when somebody has a BRCA mutation, because let's say they have a family history of pancreatic cancer and they have a BRCA2 mutation, but it's not one of these founder mutations. Well, if they did 23andMe, which only looks at these 3 points, they're going to get a negative result, but they're not really negative. So we call that a false negative. And if we look at these points along the BRCA1 and 2 genes, there are actually, we know, about 3,700 different places where there can be disease-causing changes. And when we look at all the literature, all of these are going to be causing what we call this hereditary breast and ovarian cancer syndrome, which also involves pancreatic cancer. However, with 23andMe, if you only look at 3 of them, then you're really missing 3,697 or more of these points that are just not being tested. And so I think that this graphic gives a really good summary. If the whole circle represents all of the disease-causing variants in BRCA1 and 2, this little sliver right here, the pink sliver, shows which ones are actually tested by 23andMe. And so I think this really does a great job of helping you visualize this and showing you why this is not comprehensive, because the medical testing we would order would include this whole circle, or at least close to the whole circle. So when we think about the different syndromes that are associated with pancreatic cancer, it's not just BRCA1 and 2. There are also these other syndromes that I mentioned earlier. And if we look at what the National Comprehensive Cancer Network, or the NCCN, recommends for somebody who has a personal or family history of pancreatic cancer, they recommend at minimum to get these genes tested. So this is the bare bones minimum, least amount of genes on a panel that should be offered to somebody who has a family history of pancreatic cancer or personal history. But if it were up to me, it would be a larger panel. But for the purposes of what I'm about to show you, I'm just going to show you this minimum gene list. So here are these pancreatic cancer, what I'm calling core genes. If you were to do this testing through a medical provider, healthcare professional, all of these would be tested. Now, when we look at 23andMe, the only two that are tested are select variants along BRCA1 and 2. If you were to look at Ancestry Health, when they were doing the SNP testing, which was prior to July 2020, only select variants were tested, and it's missing a lot of these genes. And now they are actually doing next generation sequencing. However, you're still missing some really important genes like CDKN2A, which is a common one in hereditary pancreatic cancer. So, and it's not as close of a detection rate as a typical medical genetic test would be ordered through a healthcare provider. So as you can see, these tests are not by any means comprehensive for a person who is testing for the purpose of figuring out if they have a hereditary risk for pancreatic cancer. So why would somebody do one of these others instead of a healthcare provider? Well, usually the answer is price. But what is the actual price? Let's look at that. If you do it through your healthcare professional, it's typically covered by your insurance if you fit a specific criteria that I'm going to go over in a second. But if it's covered by insurance, most of the time the copay is between $0 to $100. If it's not covered by insurance, or if someone doesn't fit the criteria, then it's $250 self-pay out of pocket, no more than that. Should never be more than that. If you look at the cost of these other tests, $199 for 23andMe and $150 to $199 for Ancestry plus subscription costs, you're really not getting any deals here. So it's actually more cost effective to look at, to have genetic testing through a healthcare provider than it is direct to consumer. And that's usually a reason why people do direct to consumer, is because they assume that it's going to be thousands of dollars, and it just isn't. And they're not getting all this other risk assessment either. So what does the NCCN say about who should get genetic testing in cases of pancreatic cancer? So when we're talking about specifically these exocrine pancreatic cancers, or the pancreatic ductal adenocarcinomas, which are over 90% of all pancreatic cancers, then they say all individuals that are diagnosed or their first degree relatives should be offered this testing. What that means is that anyone who has it, their parents, their siblings, and their adult children should all be offered genetic testing. And so this should be covered by insurance, because this is a guideline that most insurance companies follow. And it also goes on to say that there's a significant benefit to family members in testing these patients near the time of the diagnosis. So another reason to do it through a healthcare provider, because you'll be able to get that information more quickly and more easily integrated into this person's care and the family's care. So I don't want to poo-poo direct-to-consumer genetic testing. I think there's some really great qualities to it. Like, it has increased interest in genetics exponentially. It's increased the number of people who get tested at all, who are starting to wonder about their own genomes. It's increased general education. It can be done anytime. And it's really great for ancestry testing because of the technology that's used. But you get a lot of false negatives because these are not comprehensive tests. There's no genetic counseling or ways to address people's concerns if they were to get a positive result. There's not a comprehensive evaluation, so it's not looking at any risk factors or even other genes that could interact with the genes that are being tested. So it's really just looking at a very, very, very small piece of this big puzzle. And it also misses a lot of mutations, and it misses genes. So if, like I showed you, if you're going in for a specific indication, none of these direct-to-consumer tests are comprehensive enough to cover all of these minimum gene lists. So how do we mix the ease of direct-to-consumer testing with the completeness of testing with the provider? And that's where we have this new thing called patient-initiated testing, or PIT. And this testing provides oversight from both the physician and a genetic counselor, and make sure that this test is appropriate and safe. And so they look at multiple things when somebody orders a test. And so the way that it usually works is a person actually goes online and initiates the process of genetic testing, and then they are sent to a genetic counselor or to pre-test education, and the same pathway goes, and then they get post-test genetic counseling as well. So this is a really good hybrid of the two models to allow more people to initiate their own testing and to learn more about their own genes, while also getting the most appropriate and affordable test. So Color Genomics was this company that really kind of started this pathway of testing, and they are now pivoted and are now really focusing mostly on COVID, but you can still order testing, although you can't really order the just cancer anymore. I think it's the extended test, which is cancer, cardio, and some other medication response information. So that can be ordered or patient initiated. But Invitae has really stepped up its game, and it's a laboratory that we use a lot in the actual diagnostics part of our job, but they are offering this patient-initiated workflow as well. And other labs are soon to be following. So this may be the future of the way that we can get genetic testing. But hopefully after today, I've convinced you that genetic testing alone is not sufficient, that you should really have this whole comprehensive evaluation. So if I have convinced you, how do you find a genetic counselor? Well, the simplest way is this tool called findageneticcounselor.com, where you can actually find one in person or through telemedicine. And you can find one near you. You just enter your zip code, or you can ask the Ralph Foundation about the local genetic counselors that they recommend if you are in Chicago. Now, the other option is using telemedicine services. And there are several companies that provide telemedical genetic services throughout the country. And since cancer genetic counseling doesn't typically involve a physical exam, but it does involve a discussion, it really lends itself to telemedicine. And a sample can easily be collected at home and sent back into the mail, whether it is blood or saliva. They can send out somebody to do mobile phlebotomy, or you can just spit in a tube. And it makes it very easy to have this whole process all at the comfort of your home. So one of the companies that I want to mention, because I am working with them part-time, is Genome Medical. They are really innovators in this space. They've made it very, very affordable and easy to get very quick genetic counseling and genetic testing, just like I said, in the comfort of your own home. So if you're interested in that, you can look at genomedical.com. And how do you prepare for your visit? Well, I'm glad you asked, because together, the Ralph Foundation and I have created this worksheet. We did this last year, and it's really a great primer of information that you should be collecting to bring into any genetics provider or even your doctor if you're interested in having a genetic evaluation or a risk evaluation. Aside from collecting pathology reports, this is pretty much everything that they would be asking about. So if you are interested in doing genetic testing, I highly recommend visiting this link and downloading this kind of cheat sheet and or worksheet to be able to bring into your doctor. And in summary, if you're going to leave with anything, I think the three main messages I want you to know is that genetic testing and genetic counseling are separate, but they can be combined to give the best outcomes and risk assessment. That genetic testing with a healthcare provider is actually more cost effective and comprehensive than testing with direct-to-consumer testing. And if you've had direct-to-consumer testing, you have not had a comprehensive medical genetic test. So that being said, I'd love to answer any questions that any of you have. And I need to plug in the computer too. I didn't realize that. Give me 1 second so I can grab the charger.
No problem. If you do have more questions, I see that a couple have been coming through. So if you do have more questions, please go ahead and put them in the chat, and we'll be sure to ask Dena and make sure she gets answered.
Okay. I'm back.
All right, thank you. Okay, so first of all, thank you for all that information. It was so fascinating, and you know, it brings up so many questions, and a lot have come in, so I want to jump right in. Our first question is, my dad had pancreatic cancer and my mom had colon cancer. I'm 35 and want to get genetic testing. Should I ask my doctor to order it for me, or should I find a genetic counselor on my own?
Great question. So I always recommend genetic counselor. You can have your doctor refer you to a genetic counselor, because part of my job is working with someone's healthcare team. You don't know how much training your doctor has in genetics. And if you do know, and you know that they have a lot of training, great. But most doctors, as I said earlier, have not had a lot of training, or they had it, but it was, you know, before it's been updated, and it gets updated like every year, the recommendations and the genes that we test. So I do recommend seeing a genetic counselor. I think that's the best way to go about it.
Okay, great. How often should people get genetic testing done?
Oh, that's a great question. So it depends on how many genes you had tested. So if somebody was only tested for BRCA1 and 2, then, you know, there's all these other genes now that we know a lot more about. So if they were tested maybe 10 years ago, a lot of people were only tested for a few, and they should have update testing. But if they had a panel done, a panel of many genes, that is most likely up to date. And so I usually tell people to keep in touch with your genetics provider. And we usually say every 1 to 2 years, you can call and ask if there's any updates. Not that you need to get tested every 1 to 2 years, but it should be that you can keep in touch and have this ongoing relationship with these people.
Okay. So we talked about how to find genetics counselors. The question we always get when we talk to you is, can people work with you? So let's start there.
Sure. So as a genetic counselor, we have to have a license in the state that the patient is in. So I am licensed in the state of California, and then there are several states that don't require licensure. So if somebody is in one of those states, or they're in California, I can see them. Otherwise, I trust my colleagues that in Illinois that can see you. I can also, if you reach out to me, I can help you find somebody near you. Or you can look at Genome Medical, like I had showed, because there's many people who are very well qualified that can help as well.
Great. And on the Find a Genetic Counselor website, is that US based? Is it national? We have a question about finding a genetic counselor in Canada.
Oh yeah, there's a lot of Canadian genetic counselors. I'm not sure if that tool is US based, but there are, I think it works in Canada too. But the other thing, there's a Canadian Board of Genetic Counseling. So I think you can look at their website. And there's an American board, ABGC, the American Board of Genetic Counseling, that I do believe includes Canada maybe. So those are, you may be able to find, I need to actually look into that, but I'm pretty sure that, I know there are a lot of Canadian genetic counselors.
Okay, great. And if you find additional information, we could always put it in the Facebook chat afterwards.
Yeah.
So that's great. Our next question is, she says, my father recently passed away from pancreatic cancer. I'm so sorry to hear that. When he first got diagnosed, my family and I did genetic counseling, but they only tested one more experimental gene, MUTYH. Should we still pursue further genetic testing?
So I think it depends. I would have to see the panel that was done. So it depends. Yeah, it depends on, I'd have to see. So I think maybe just calling your genetic counselor that did the genetic counseling with you, and asking them if there's any updates or if there's any additional testing that you can do.
Okay. And she followed up saying they only ran that one because that's the one that stuck out from her dad's genetic panel. Does that differ your answer at all?
I'd have to see what it means to stick out. So you can have a positive result or a pathogenic variant. You can have a variant of uncertain significance. Those are both going to be considered findings, even though only one is really a relevant finding. So I don't know. Yeah, again, I think that it's situational. I'd have to look more into that.
Okay. Our next question is, I'm on COBRA now and not sure if it's a good idea to get counseling until I'm on a solid plan. Have patients had backlash of pre-existing conditions if this comes back positive? I have 4 relatives with pancreatic cancer.
Yeah, great question. So, okay. there's this law called the Genetic Information Non-Discrimination Act that is a federal law in the US. There also are state laws, state versions of this law. It prohibits health insurance and employment from discriminating against somebody based on a genetic test result alone. Now, if somebody has already had a cancer, the law does not apply to them because they're not asymptomatic. So it really only applies to asymptomatic individuals. So with somebody who has not had cancer, but they have like a high-risk gene mutation, they are protected by this law, like I said, from health insurance discrimination and employment. They are not protected, however, from life insurance. So if you do try to take out a new life insurance policy or a new disability policy, they can ask if you've had genetic testing, and you have to report that you had, otherwise it's considered fraud. And then they can technically raise your rates or deny coverage based on that. There's some legislation that's really working on that right now to get life insurance to be covered or to have some sort of coverage so that they can't ask that. And not every life insurance will ask that. And if you already have a plan, they're not going to, doesn't matter. It's only if you're taking out a new plan. But that is really the main thing that I talk about in my session before someone does a test, is to get life insurance before you do genetic testing, just in case.
Sure.
Yeah.
So that goes into another question that we have. How private is the information when you are using the 23andMe and Ancestry? How private is the information that you're giving to them?
Yeah, so that's the thing. So there's a lot of so 23andMe uses a lot of this aggregate data. So they're not selling just your individual data, but they're using their data all together to sell to pharmaceutical companies, to sell to other places. And I'm not sure where they are now, but they were, and it was for a good cause. They're doing it for research, right? And they're doing it to be able to detect things that no other database is able to find and to make new discoveries. But a lot of this is in the small print when you actually do 23andMe. So if you go back and you look at that, or if before you do it, if you are considering doing it, you should read all of the fine print. It will actually say that. And you can opt out of research and you could opt out of this data sharing. But you know, it's definitely not at the same level as a medical testing company where they are not selling this data, where you have to opt in to doing research. And it's really dependent on the company itself. So I usually have, if patients are worried about that, I have them call the company or the laboratory that I'm going to order from and ask them specifically their questions and talk about their concerns with the company itself.
Okay, that makes a lot of sense. So how about the folks who have the results from 23andMe? In fact, we have somebody who just said that they have a cancer marker tested in one of the OTC or one of the companies and got results at a high risk on pancreatic cancer. So what should she do next? And should they be worried?
Yeah, great question. If it is a direct-to-consumer test and it told you had high risk, the next thing to do is get that confirmed with medical testing. So anytime someone comes up on these direct-to-consumer companies with something positive, no matter what it is, it needs to be confirmed with the level of testing that we would do in a clinic. And once it's confirmed, then we can work from there and figure out if you really have that and then what you can do based on that. But so interestingly enough, some people will take their raw data from 23andMe and they'll run it through these third-party software programs. And there was a study done by one of the major laboratories that actually found that there was a 40% false positive rate for people with cancer gene mutations. So meaning of all of these people that were told using their 23andMe or their Ancestry DNA raw data and running it through this third-party software, that means that of all these people that tested positive or high risk, 40% of them were not really truly high risk, which is a horrible number. It's almost like flipping a coin. And so I tell everyone, I warn everyone, it is the third-party software is completely unregulated. And I did a lot of this confirmatory testing and found all of these people were negative. They didn't actually have it and they were losing sleep over it.
Sure.
And they didn't actually have it. It was just an error in this, because you're taking data and then you're putting it through another system that puts it through another system, and there's a lot of room for error. So when you're talking about something that's so important as your health and your cancer risk, it's really not worth it to do something cheap. It's just as affordable to go get something high quality as it is to do something cheap.
Right. And it kind of goes to the notion of being more comprehensive. If they do have that, though, would you recommend them bringing it to the counseling meeting just to say,
Yeah,
here's
definitely.
Okay.
Yes, I do. Because the thing is that, so for instance, for me, when I had these patients come in, they were told they specifically had Lynch syndrome. So those were some of the patients I saw. So they were really worried. And what I did is I did a whole evaluation. I took their family history, I took their personal history, and there were no signs. And then I did the actual genetic test, and of course they were negative. So I wouldn't have known what to test for. You know, I mean, it would have been hard to get that covered. And yeah, so do bring that in.
Okay, great. Okay, our next question is, I was curious if you know any of the resources that offers financial assistance for testing for those who don't have insurance or insurance won't cover the cost. We see that it's around $200, but even that might be too high for some people. Is there any assistance there?
Absolutely. So the laboratories are really good about this. They are very good at, there's a threshold of income that you have to meet to fit this financial aid category, but it's actually very high. So it's very easy to meet this threshold of income so that your test can be free. And I had a lot of patients get free testing because they didn't meet. In San Francisco, at least, it was a higher threshold, but it just depends on the laboratory and where you live. But it's very, very easy to get this financial aid straight from the laboratory. And there are other ways to get it as well. But you're right, 200 is too much for some people, even just 200. So there's many financial resources available. And that's one of the reasons it's helpful to work with a genetic counselor, because part of my job was navigating the finances of this test as well.
And when you do meet with people, is it one initial meeting, then the tests, and then one follow-up meeting? Is it an ongoing relationship? How does that work?
Yeah, typically it is a pre-test counseling visit, the test, and a post-test visit. That's the traditional model I was talking about. So that is usually, for me, how we're doing it. Some people I'm doing pre-test, and that because their doctor ordered and because of the work I'm doing just pre-test. But yeah, typically it's not a consistent follow-up. The only thing that's consistent is that when I was working in the clinic, I would tell people every 1 to 2 years to call in and check if there's more genes to be tested, check if your variants, like if they had these inconclusive results or these variants of uncertain significance, I would tell them to call back and see if they've been, if we know the significance of them now. So that's the ongoing relationship. It's not coming in every year, but it's just keeping in touch every few years.
Okay, that makes a lot of sense. So it seems like, these over-the-counter ones the 23andMe's are more for entertainment purposes. There's interesting, fun little pieces that you can find out, but nothing that you should really base your health on.
Yeah, absolutely, yeah.
Can we talk more about what other types of questions should people be asking you when they come in?
Yeah, well, should they be asking me? So I think that there's a whole process with evaluation where I ask people a lot of questions about their history. I don't know about what questions they should be asking me. That's a good question. I think that will come up usually when we do discuss their history.
Okay.
And it's very situation based. Yeah.
I'm sorry, say that again?
I just said it's very situation based.
Sure. So basically somebody could come in and just talk to you. They don't have to prepare much. Yeah. Okay. And what if somebody doesn't know their history, whether they were adopted or just don't know how far the lineage goes?
Yeah, no, I've had those patients before. A lot of adoptions, a lot of, they were like sperm donor babies, or one of their parents was adopted, and that's okay. Obviously, we can't have all this information, or sometimes people just are estranged from their family. So what I do is I try and get one of the main reasons besides the risk assessment is also to be able to get this genetic testing covered. So I want them to fit this criteria so that they can get it covered. And if we don't know their family history, there's a way to claim what's called limited family history, which just means we don't have enough history to know if we would see these patterns of cancer, so this testing should be covered. So that's one of the ways that I will claim that I think that testing should be done. But either way, it's getting to the point now where, because of that $250 self-pay rate, if someone's interested and they don't have family history and they don't fit criteria, they can still do it. You know, with this patient-initiated testing that's being done, anyone can get testing. And I think that's really great. It's really opening it up for lots of people.
No, that's really, really wonderful. I mean, because it's so important. Let's talk more about the Know Your Risk worksheet. Can you kind of talk us through the different questions there and why those are the important questions to kind of think about?
Sure. So let me just, I'm going to pull it up so I see.
Okay.
Okay. So the first section is about personal history of cancer. So it's really important to know that. And that includes not just pancreatic, but skin cancers. It includes like precancerous polyps would be important information there. But any types of lumps, bumps, cysts, growths, polyps can be, that comes later on the worksheet. But this is first of all looking at cancer type. Age of diagnosis is also really important. That gives us a lot to think about when we're trying to assess someone's risk. And then the second part is a family cancer history. And again, the person's relation to you, the type of cancer, the age of diagnosis, if they're still living or not, and then their current age, that also tells us information. And then I talk about, it says to bring in pathology reports, and that's very important. So especially in pancreatic cancer, we want to know if it was an endocrine or an exocrine, or if it's a certain type of tumor, because some of these rare pancreatic tumors are associated with rare syndromes that may not be included if you don't know what the tumor is. So that's important if somebody can get the pathology. And then there's also more family history, and we're talking about, I asked about pancreatitis, precancerous colon polyps, benign tumors or growths, atypical moles, hyperparathyroidism. And the reason I'm asking about all of these things is because these are all flags for certain syndromes or parts of syndromes that I think would be important to know that people may not think about, and so they leave off. And so if we can say yes or no to these things, it can be very helpful. And then how many relatives in my closer extended family have had pancreatic cancer, that will also help with figuring out if someone fits criteria for testing or also their risk assessment. And then the type. So that's where I have here, which type was it? And then also it says, does my family have any Ashkenazi European Jewish ancestry? And the reason for that is that the rate of pancreatic cancer is increased in Ashkenazi Jews. And part of that is because there's a 10 times higher chance of having a BRCA mutation. So those 3 founder mutations I talked about earlier in Ashkenazi Jews are 10 times more common in Jews than any BRCA mutations are in other populations. So that's a guideline. Now, I think that they're also going to eventually probably be adding other ancestry groups, because we know that African Americans have higher rates of BRCA mutations as well. There's a lot of research that has come out. And I actually do want to put a little plug in. A project I'm working on is called Black Cancer Genes, and it is a patient advocate, or it's an education initiative to educate more people about the rates of these hereditary cancer syndromes in the Black community, which were once thought to be low, but they're really not. And so eventually maybe it will ask about African-American history or Black, being part of a Black community as well. And then there's the last part of this, which is genetic testing. Has anyone had genetic testing, or and what were the results? Because that's really important as well when you do. And then if someone's been found to have a change. And I think the last part, is just information. So those are really the main things that are on the worksheet.
Okay, great. And we have it in our chat, but you can go to knowmyrisk.org and fill that out. Dena, at the beginning, you had talked about how you work with people's healthcare teams. So if there is a diagnosis, what does that look like? How are you partnering with the healthcare teams?
Yeah, so usually what would happen is a patient would be referred to me, and I would do this evaluation. I would look at their genetic test results, and then if they fit if their risk was high enough, there's different protocols that we follow. So there's these guidelines called CAPS guidelines, where and I'm sure lots of people here know about that. When we talk about the endoscopic ultrasound screening and MRIs, that would be, you have to be at a certain risk for that to be offered. So being able to assess that risk and then go back to the doctor, the team of healthcare providers, and say this patient fits this risk. Here's what the national guidelines say, and kind of going back and forth with the doctors and figuring out what's going to work for that patient. And then they're the ones that are going to actually order this screening or this type of testing or a medication. For instance, in Lynch syndrome, we know that taking aspirin decreases the risk for cancer. So there's a lot of things depending on someone's diagnosis and their risk factors that I would talk with their healthcare providers about incorporating into their plan.
Sure. It seems like that's so important to have, all the different pieces to the puzzle and everybody informed so that people are getting the best care possible.
Right. Exactly. Yes.
So I really appreciate all of this information. It's so, like I said at the beginning, it's so fascinating. Can you go through your key takeaways one more time of just what you're hoping folks can walk away with? Because I think it was really important and something that we should really repeat.
Okay, I think, the main things are that genetic testing and genetic counseling are separate, and together they give somebody the best and most comprehensive risk assessment. And I don't know if I said this earlier, but there are definitely situations where people are really, really anxious about their risk, and they come in and then it's not as high as they thought. And they leave in a much less anxious state because they realize that their risk truly isn't what they thought it would be. Or they're not sure what their risk is. They come in and they actually feel better because we have a plan in place instead of just having uncertainty. So the genetic counseling is really, the reason the word counseling is in there is because it really can benefit someone's state of anxiety. And even if you don't feel like you have anxiety about this, you probably do. Unfortunately, it would be very abnormal for someone to really not fear risk for something that runs in a family. It's a very human thing. So that's one take-home point. And so people can also come in and have counseling and decide to delay testing or not to do testing yet. And then there's the other point was that genetic testing with the healthcare provider is actually more cost effective than direct-to-consumer testing. So there's a big misconception that it's really pricey to see a genetic counselor and have testing, and so that's why a lot of people turn to direct-to-consumer testing, because they feel like it is the cheap sale version of it, and that insurance is really hard to navigate. It's not transparent, but if you see a price online, you click that and that's your price. Of course you're going to want to do that, but in the end you end up saving a lot more money and getting a lot more bang for your buck if you do it the way that I was talking about. It's more comprehensive, it's more cost effective, and it will help you a lot more in your healthcare plan than something like a direct-to-consumer test. So that's the second point. I think the third is that if you've already had 23andMe, you haven't had BRCA testing. And that is the number one thing people say to me is, oh, well, I didn't have it, I did 23andMe. Okay, but that, hopefully after you watch this, you understand. I hope I drove it home that is not BRCA testing.
Sure. Well, that's great. Thank you again for all of this really great information. Tell us again where we could find you.
Sure. So I have, I'm on Instagram, I'm on TikTok, I'm on YouTube. Well, you can look at www.DenaDNA.com. I'm on Twitter, I'm on all these things. So I would love it. Any social media platform you're on, I'm probably on it. So please follow me. That will help support me and what I do. I do a lot of pancreatic cancer associated things. I do a lot of just hereditary cancer associated things, and other genetics as well. So I would love your support in following me on whatever platform of your choice.
Of course. And for the record, it's DenaDNA.com.
Yes.
That's how we're spelling Dena. And we put that in the chat as well. So you can go ahead and follow Dena and stay up to date on the current genetic information and findageneticcounselor.com for finding a genetic counselor to get the information and just the talk that you need to see where you need to be. That's where you should go there. I hope, if you're joining us in the replay, please write replay in the comments and add your questions in there, because we'll send them to Dena and we'll make sure that she answers them for us and we'll get back to you. And I hope that you'll join us next month. So on August 11th, we're talking about an often taboo subject. We're talking about grief. And we're partnering with our friends at the Cancer Wellness Center and bringing a variety of perspectives on grief. You know, how you can work through it, the flood of thoughts and emotions that come along with a cancer diagnosis, and what grief looks like, and that it's okay to grieve through this. So I hope that you'll join us. You could register for this event now using the link in the chat. And remember, as always, if you have ideas for future Wellness Wednesdays, please send those to us at info@ralphfoundation.org. And we want to, on behalf of everybody at the Ralph Pancreatic Cancer Foundation, we want to once again thank Dena and thank everybody who's joined us tonight for this Wellness Wednesday. We hope that you continue to do your part to stay safe, and we look forward to seeing you back here next month. Thanks and take good care.
Thank you.
Bye-bye.
Bye.